Thank you, Stefan, for the invitation, and everyone here for your interest. My name is Jana. I'm a psychologist in the Maastricht University Medical Center, where I work within the tinnitus team clinically, and I am also part of the research group that is investigating the brain stimulation as a treatment for tinnitus. I would like to tell you today a bit more about the process that our team went through to get to our first study, tell you a little bit about how that went, and what our future plans are. So the brain stimulation, or DBS, is an neuromodulative treatment where using stereotactic surgery that you see on the left, an electrode is planted into a specific brain region, and there's a pulse generator that is placed either under the collarbone or in the belly, and that gives electric pulses to that specific brain region in order to modulate the activity there. There's a long history of using DBS here in Maastricht. Usually it's, or in the beginning, it was mostly used for movement disorders such as Parkinson's and essential tremor. Then they moved on more into neuropsychiatric disorders such as OCD and epilepsy, and also Gilles de la Tourette. And then at some point, one of our colleague ENTs had the idea maybe we can also start using this for tinnitus. Jasper Smits was the first PhD student who started working on this project. He contacted Professor Temel to see whether or not there were possibilities to use DBS in tinnitus. There was already some evidence showing some incidental and case reports of potential treatments, as well as small trials that had already been done, but they had never been done in the auditory circuitry. So as preclinical research, my colleagues started with a rat model of tinnitus. Gusta van Zwieten and Jasper Smit both did these rat models for 3 different locations in the brain. So the medial caniculate body, the inferior colliculus, and the dorsal cochlear nucleus, where they used the rats to show whether or not tinnitus behavior was adjusted after DBS. And they showed that in all 3 of these locations, tinnitus behavior in rats was suppressed using high frequency stimulation. And there was no evidence of hearing loss after DBS in these rats, so at least not because of the stimulation. This was actually good to know, because now we had an instance to start from. Next, Jasper Smits did a study on whether or not patients were actually willing to go through DBS for tinnitus. And we actually found that 1/5 of our patients was willing to undergo invasive treatment, and another 1/5 was fully willing, which even meant if there was a chance of dying during the surgery, they would still try it or want to try it. We didn't just check for DBS, but we stayed in very general terms, speaking about invasive treatment, so that it wouldn't not be too biased. But that meant that we had some potential targets that we could work on. These all 3 were potential targets. However, in humans, we chose for the medial caniculate body, mostly because stereotactically it was in a more easy spot to reach, and there were less large blood vessels closely to it, so that surgery would be expected to be more safe. We looked at potential side effects by looking at the brain regions that were close to it so that we could potentially know what we could expect. Mostly, we would expect effects on eyes, so seeing phosphenes and deviation of the eye position, or disturbances in movement and also feeling. I'll get back to that later, whether or not this was actually the case. But we set up a safety and feasibility study with our target was to see 6 patients where we would bilaterally implant in the medial geniculate body. We wanted to measure the effect of DBS on tinnitus. We wanted to monitor the side effects on also on hearing and neurophysiological functioning, as well as see whether or not we could do some research on the neurophysiological hallmarks of the MGB itself. I'll walk you guys through our study. So first we had the inclusion. This was an extensive intake procedure where they had an interview and questionnaires. They had to see our ENT specialist to see whether or not there were other underlying causes for the tinnitus. Our neurologist and psychiatrist also checked the patient. Psychiatrist mostly checked for depression and anxiety which is expected to be there, but if it was a pre-existing condition that was not caused by the tinnitus, then that was an exclusion criteria. Our neuropsychologist did a neuropsychological survey so that we could afterwards also check whether or not their neuropsychological functioning had changed. And they had to have received standard care here in the Netherlands. So that means cognitive behavioral therapy for tinnitus, and they still had to be refractory to treatment. They also received an MRI and a CT and an EEG so that we later could also see whether or not the neurophysiological functioning based on the EEG was changed. Then we had a multidisciplinary meeting where everyone had to agree whether or not a patient could be included. Here you see our in and exclusion criteria. You can also obviously look back at it in our paper on it. But most importantly, tinnitus had to be refractory to standard care, had to be non-pulsatile, both uni and bilateral tinnitus was okay. Tinnitus had to be severe still after treatment, and it had to be chronic and stable, which meant having at least tinnitus for 2 years. Exclusion criteria, most importantly, were other psychiatric disorders, pre-existing anxiety or depression, cognitive impairment, and the other general treatment exclusion criteria. Next, there was bilateral implantation. This is an awake stereotactic surgery where both sides an electrode is implanted with one IPG. We expected to test frequencies between 2 and 200 hertz. In the end, we ended up with a more high frequency around 100 hertz as what we were using. You see the other parameters as well. Also, we had the possibility in our care that if someone had unilateral tinnitus, we could also test unilateral stimulation. Then there was a double-blind crossover design. We tried to do this as blinded as possible. However, we know that blinding was very hard in these patients. You cannot obviously not blind treatments, surgery. So we tried to blind treatment using a staggered turn off of the stimulation, but they are aware of stimulation being present. So that was a hard part within the treatment. This was also balanced over the patients. Then we had a 6-month open label of stimulation. So there was an evaluation of long-term effects, and afterwards they were entered into standard DBS aftercare. This meant that they get, if they want to keep the electrode in place and use it, they could. If they wanted it to be removed, we opted for removing the battery and not the electrode because there's more side effects or more risks when extracting the electrode than just the battery. In July of 2021, we did our first surgery. I'm still very proud of our first patient, mostly because he was so brave to actually go through this as the very first person. In his case, we saw that actually after 1 year follow-up, he had moved from a grade 3 tinnitus to a grade 1 tinnitus based on a tinnitus questionnaire. You can also see that his other measurements have made a similar trend, and we also see that, for example, his quality of life had also gotten better. What did we see as side effects? There were mostly physical sensations in face and extremities. This has to do with the white matter tracts that are close to the MGB. But these were all transient and only dependent on the stimulation. So this meant that whenever you would turn stimulation off or lower, it would actually fade. Their hearing remains stable. Also, when stimulation was turned on. And there were no adverse events based on the DBS itself. In the end, we only ended up with 4 patients that we included. This had to do with how the setup of the trial was. But 2 patients were included based on not having tried hearing aids. Some patient ended up being actually very happy with the hearing aids. And 1 patient had severe misophonia alongside of it. But if we look at these 4 patients, we see that 3 of them had a similar trend as the first patient. The first patient had the biggest effect. And we see that 1 patient actually had a worsening of tinnitus over time. That's why we also checked the electrode placement, and actually it turned out that the patient who had the worsening of symptoms, his electrode was furthest away from the targeted area. So we actually seem to have an indication why this happened. What will we do in the future? Actually, our group is in the ways of setting up a larger trial to better estimate the effects. I cannot share that much about it yet because we're still working on the setup. And next to that, I'm also working on an analysis of the population of patients that were referred to us with the indication of DBS. And we are actually, because we only did surgery on 4 of them, we're actually trying to see what we actually did with these patients in the end, and if they were helped with that care path. So that maybe we can also give others advice on how to proceed with treatment of these very refractory patients that all of us see every once in a while. That was about what I wanted to tell you. I obviously want to thank our entire team that is working very hard on this or has worked very hard on this.